आज जो मन की बात के लिए हम इकट्ठे हुए हैं, हमारे सामने 6 लीजेंड्स क्रिटिकल केयर स्पेशलिस्ट है और ऑफ डायस भी इतने बड़े क्रिटिकल केयर स्पेशलिस्ट है. Just we are going to ask the question that put on that box. First question is, I would ask to Dr. Raval, who is a very senior critical care specialist. When a patient is admitted in the ICU or we ask about the ICU, the relatives care about the cost. वैसे भी ऐसे हुआ कि जैसे मैंने मित्रों बोला तो सबने अपनी पॉकेट देखी कितनी 2000 की नोट है या 500 की नोट है. So I will ask Dr. Raj, how we can reduce the cost in ICU?
Actually, this is the last question to be answered in this Mann Ki Baat. See, cost is a very, very important aspect as far as the India is concerned, because most of the socio-economical status is just middle class or lower middle class majority. So cost is a constraint all the time. It is difficult to curtail when you require quality. So again, the patient, or rather than if you are a patient, you have to choose where you have to cater. Means like you want to go to 5-star, or you want to go to 4-star, or you want to go to dhaba. Ultimately, you have to decide. Otherwise, it is very, very difficult. The question is open for all other my friends.
I think quality is not proportional to the cost also. That as an intensivist, how we can approach to the patient, I will ask any other that panelist.
Cost reduction would be, I think it's always like we do individualized critical care. So in patients, we have to individualize. Some patients, if you try to cut off the cost by reducing investigations, then you end up burning your hands, because then you miss out on something. So our attitude should not be to cut down the treatment and the investigations. First, we should start with the most important costly problem in our ICU is infection. So we should focus on infection control. It is always better to avoid using higher antimicrobials rather than select something which is of low cost and then you end up giving a low quality molecule, you never know. So it's like preventing complications is the best way to reduce cost in your ICU. But once there are complications and your patient is in ICU, then we should not try to restrict the investigations, because most of the time we end up burning our hands. And I have seen in my practice, whenever there is a patient who is not much affording, and we try to save the cost on something and the length of hospital stay increases, and then we regret, oh, this need not be done. So we have to be rational in our treatment, but focus should be only on prevention of complications to reduce the cost. Otherwise, you can always negotiate with your management and keep the cost down for treatment.
Okay. Any other panelist?
When you have a very small unit, it's very, very easy for you to control the cost. At the same time, if you have a very big unit, very big department, and what happens is in each shift there will be a registrar, he will ask for some investigations. So these are certain things where you can probably make a control. You can see how you can reduce the cost in those particular aspects. Many times we see in bigger units, registrars, when they're around, they want to do something more. They keep on ordering infections. So in our unit, we have made it mandatory that certain times investigations, routine investigations, for example, you need not ask for a urea creatinine, calcium, magnesium every day. It's not needed at all. So routine investigations, there has to be a way by which you can cut down on the cost. This will definitely have a bearing on the bill. We have seen in very corporate hospitals, investigations per se, they take the biggest part of the bill. So if you're able to silently reduce certain of these investigations, smaller investigations, definitely you'll be able to come down on the cost. But imaging studies, etc., there you can never compromise. Yeah.
So it has to be individualized approach, and according to the patient, you can decide that how you can approach this. The second question is to Dr. Subbareddy, that which one is the preferred vasoinotrope support in cardiogenic shock?
Yeah. In cardiogenic shock, the preferred vasopressor is still noradrenaline, norepinephrine. But you'll be hearing from your cardiology colleagues, and then they'll be coming and they'll be telling us to start dobutamine. Why don't you start dobutamine and all? But when the already mean arterial pressures are low, starting dobutamine, again you are decreasing the blood pressure. So norepinephrine, and then to augment the cardiac output, you can start dobutamine. Otherwise, the first choice will be the noradrenaline.
My question to Dr. Dumra, that you have mentioned in your talk that what are the advantage of the therapeutic drug monitoring in a critical care?
So first and foremost, you need to understand that TDM is not available in most of the ICUs at this point of time. The turnaround time for a TDM for a single, say for example, looking at voriconazole trough levels, it takes almost 48 hours. So the first issue is therapeutic drug monitoring is very difficult to implement. It is easy to preach from the dais. But the fact of the matter is it is the future, and it has to be inculcated as a part of good clinical practice. So although we can't do it today, but we should start thinking of doing it. That is one. Secondly, TDM is essential for not only drugs with narrow therapeutic windows, it is primarily also advocated for drugs with complex pharmacokinetics. So what do I mean by that? If you have vancomycin or gentamicin, they have very narrow therapeutic windows. So excess dosage can lead to nephrotoxicity. But voriconazole does not cause toxicity, but it has complex pharmacokinetics. So it should be implemented not only for drugs with narrow therapeutic windows, but complex pharmacokinetics. Thirdly, it should be patient friendly. If a single drug level costs too much to the patient, it defeats the purpose of the entire test. So turnaround time and cost should be effective. None of this is happening right now. If you consider the state of TDM in Ahmedabad, if that is so inferior, then you can very well believe what is happening in the peripheries. So TDM is a futuristic concept which is essential to ICU management, because we know that to optimize antibiotics, we need to know the pharmacokinetics and pharmacodynamics, and we cannot predict it identically in every patient. So TDM is mandatory. Unfortunately, the level of available tests at this point of time do not support using it on a day-to-day basis.
Okay. Any other panelists? Any comment?
TDM is very useful when you are monitoring immunosuppressant levels. In the transplant ICU, it's very important. And in future, I think if you get point of care TDM testing, and then if the turnaround time is less and is less expensive, we can use it more often. But it's available, as I said, for only few antibiotics. So that is one big challenge. And then the cost is one challenge when we are doing TDM.
Yeah. Okay. The next question is, any the markers of the kidney injuries available, commercially available, that we can detect?
Yeah. In India, for acute kidney injury, I think we had a talk also in the morning. So NGAL is available, cystatin C is available, but again, these biomarkers, they are expensive. If you are getting creatinine at around 200 rupees, if you are doing, cystatin C is costing around 2,000 rupees in our hospitals. And NGAL turnaround time is good, but cystatin C will take around 8 to 10 hours to get. But I don't remember one company, I think they're launching KIM in India, that is kidney injury molecule, point of care testing. We don't know, we have to see the cost and all. But creatinine with the drugs, with the body mass, there are a lot of, lot of variables are there for creatinine. For cystatin C is better if it is cheaper, and then if the turnaround time is less. And then even we can calculate the creatinine clearance by using CKD cystatin formula. So that is one advantage.
So there is going to be a launch of a new kidney biomarker, at least in Ahmedabad, in the next 1 week. It is called PenKid. It's a point of care test. I think the product is pancreocephalin. What it does is basically, as far as NGAL and cystatin C are concerned, they are affected by inflammation as well. So the markers are not so biospecific. PenKid is very specific because it functions independently of inflammation. Say for example, if you have a hepatorenal syndrome, the hepatic component itself can increase the level of biomarkers for kidney malfunction, but PenKit will not do that. So it's a point of care test. The costing is again an issue for point of care tests, but I suppose with usage across the board, costs will be brought down. And it's an excellent biomarker for emergency medicine. In fact, I was just talking to some of my colleagues about this, that it can help you segregate between acute kidney injury and chronic kidney injury. So if you have a patient who walks to the emergency room with a creatinine of 2.1 and you are not sure whether this is CKD or AKI, that simple PenKit level, if it is normal, it clearly indicates CKD. That means there is no acute insult. So it focuses on acute care. So that's why it will be a game changer for us. It should be available in the next 1 week.
Okay. It differentiating between the acute and chronic.
There are multiple uses. So it precedes changes in creatinine. So if you have, say for example, a patient who has a creatinine of 2.7, you want to subject this patient to a CT contrast, or you want to undergo, this patient needs to undergo a coronary angiography, and the creatinine is 2.7, and the patient is recovering. You want to schedule this procedure. If the creatinine is stuck at 2.7, but your PenKit levels start coming down, it clearly tells you that the kidney has started recovering. So you can schedule the procedure even if the creatinine has not improved. So it precedes changes in creatinine.
Okay.
So it is a biomarker which precedes changes in creatinine, precedes alteration in urine output. So it's an early marker to tell you a lot of stuff as to what is going on with the kidneys.
I would like to question Dr. Jay Kothari that most of time the end of life care issue that you are working in ICU for I think more than 2 decades. So what is your opinion how to deal that end of life care issue in certain conditions?
Well, a lot of things have been spoken as far as the podium, as far as the guidelines, textbooks, critical care conference are being discussed. But at the bedside and at the corporate hospital and with the patient and family, talking to end of life issue has to be very, very individualized and very, very subjective, because the different family have different level of understanding. And we most of the time, and many of such kind of times, it becomes difficult. If we had a patient who had cardiac arrest recently, neurological outcome is not there, and we want to tell them that okay, do not do any aggressive treatment, but then what? That patient is not brain dead, and that patient cannot go back home, and that patient stays in the hospital, and then the cost issue. So these are variable or various such kind of complicated mechanisms that happens in the hospital, which from the podium cannot be answered. With that family only, we need to how to deal with such kind of situation.
Any other comments?
You need to have a good end-of-life protocol in your hospital, and ISCCM has given a position statement for end-of-life, and ISCCM protocols are there. In our hospital, the attending physician along with the intensivist, whole team will try to initiate the end-of-life care, and then we'll talk with the family, and then we take the consent. We have a form for that, and then we document everything, what we are following, whether you are comfort care, in what aspects you are following in that. And if you look at the accreditation organizations like NABH and JCI, they look at that. So you can't save all the patients in intensive care. So if you're not initiating in one end-of-life care in your ICU, that means your ICU quality is not good. So whenever we get the JCI inspectors, when they come for the JCI inspection, they will ask, how many patients are end-of-life in your hospital? And then they want to go and check how we did the consenting, what we explained to them, and this is very important, and what documentation we are doing, how frequently we need to take consent. All these things we should have protocols, and then ISCCM has given good guidelines, we can follow that.
And when it comes to end-of-life care, you have to be very, very careful. Your junior level team, they are extremely good in managing critical cases. clinical decision making they'll be able to do excellently. But when they're going to counsel end of life to very, very critical patients, please be careful. Maybe end of life care counseling should be done with people with experience. Your junior level team might be able to manage the clinical aspect, but when you speak to the family, you have to empathize with the family. That comes only with experience. Not all your junior team will be able to do that effectively. We have seen many times when out of hours, our junior doctors have counseled, at the time things have flared up. So end of life counseling, see to that the senior level physicians, senior consultants, they do it. So when they do it and in the appropriate setting, you have to be very careful where you counsel them. It's always better to have video counseling done. In this age, with so many different opinions coming through, the same another family member will come the next day, so many conflicts will be there. Always go for video counseling and see to that a senior person does the end of life counseling. Leave the clinical aspect to a junior team, they will do it very well. Yeah.
And Jay has rightly mentioned that the end of life issues should be individualized. That is different from case to case. And the most important thing, as Dr. Subha has mentioned, that the protocol is there, but when you are doing, when you are discussing with the family, you are not treating only patient, you are treating family. So you should have a proper counseling about the what is the socio-economic condition of the family. So all things keeping in the mind, you have to present yourself in a very humble way. That is most important.
So that's ISCCM is going to launch that communication skill based that protocol guidelines in recent near future. So that is the most important thing, and it is individualized how you are doing that end of life care issue, handling that protocol based should be there. The another burning question is death of critically ill patient while transporting the patient from one hospital to the other hospital. So how we can deal, Dr. Sankalp?
Okay, death during transport, right?
Yeah.
So one issue is always who will give the death certificate. So that question is clear. I think death certificate is to be given by the last doctor who sees the patient before death. So once the patient is out from your hospital and in the ambulance, it becomes the responsibility of the ambulance people. This should be clarified from our side whenever we are transporting the patient, because after something happens on the way, the ambulance doctor tells we should give certificate. They refuse, then relatives come to us for the death certificate, and the patient has already left us. We have not seen the patient during transport. So it is clear the ambulance doctor has to give certificate. We should be careful that we hand over the patient to a doctor who is qualified to transfer the patient in an ambulance, because many times the transporting doctors are just BHMS, or there is only a nurse. Patients may have arranged the ambulance on their own. So we should hand over the patient to a qualified doctor who is MBBS, who could be anesthetist, physician, or an MBBS who is experienced in transporting such patients, MBBS with IDCCM, whatever. But a qualified doctor should be handed over the patient, and he has to give the death certificate.
So I think proper consent and the counseling of that relative is also important things while they're transporting the critical.
Yes, any transport, it depends on why we are transporting. If we are referring to a higher center, then we have to explain to the relative that there is a risk on transport, but we are going for overall benefit to the patient. If the relatives are taking DAMA and going to a lower center, then again we have to tell them that something may happen on the way. You have to take consent. And the same thing has to be reinforced by the transporting doctor, and he should also take a second consent, like a second opinion, that two doctors have told the family members that patient may die on the way. Still, if they are insisting, then the patient should be transported.
Next question
And
is,
thinking that the patient is critical, and then while transporting the patient will die, and then if you keep in your hospital without proper facility, or if you are treating a head injury patient without neurosurgeon, that is more dangerous. And in this process of transferring, even if the patient dies, court will not hold you responsible, and then we should not be scared about this. And then if we don't have that facility in our hospital, we have to explain the risk, and then we have to safely transfer.
The question is that a role of extracorporeal therapy, in particularly poisoning, that cell force poisoning, is there any role?
Yes, definitely. There is a role for extracorporeal therapies when it comes to poisoning, drug overdoses. But again, it depends on what kind of drugs. And then there is something called sieving coefficient. If you are using charcoal hemoperfusion, so if there is a patient with carbamazepine overdose, or if the patient with phenytoin overdose or theophylline overdose, simple paraquat poisoning. This charcoal hemoperfusion or this like a resin-based hemoperfusion has a better sieving coefficient. We can remove drug more efficiently or poison more efficiently. But the older the charcoal hemoperfusion had side effects, thrombocytopenia and other side effects. So now these more resin-based cartridges are available, which are safer. For some drugs, intermittent hemodialysis is enough. But if the patient is hemodynamically stable, unstable, even though the clearance is low, we have to go for continuous modalities.
So for cell force poisoning, we have been using ECMO on those patients who are very sick and serious, hemodynamically unstable, high lactate, low ejection fraction, very regularly, and we have got huge level of success for such kind of things. For extracorporeal therapy, charcoal hemofiltration has been tried in Gujarat for paraquat poisoning, and I guess Sankalp has the good experience of that.
Whenever you're thinking in terms of poisoning and extracorporeal removal, the three most important things would be the molecular mass and the amount of protein binding. If it is less than 80% protein binding, you can remove it. Beyond that, it will be difficult. So these are two important things which you should always remember. So that plays the basis on which you decide whether to go for hemodialysis, CVVHD, or any high cutoff dialysis. You can plan depending upon that particular thing. And as sir told, charcoal hemoperfusion, etc., for a week poisoning like paraquat and all, it will be of very good use.
Dr. Dumra?
So I think the point which needs to be emphasized is that ECMOs or extracorporeal therapies have to be resorted to after exhaustion of all possible options. In the sense, if you have given an antidote and it is not working, if you are faced with an organ disabling disease, say for example, you're looking at methanol and you want to you cannot risk waiting, or there are certain poisons where you have therapeutic levels. If they exceed a particular point, even if the patient is not symptomatic, you need to resort to extracorporeal therapies. So depending on the toxin, the same guideline will change. So for certain toxins, you can wait and only then subject the patient to extracorporeal therapies. And for certain toxins, extracorporeal therapies are the treatment of choice. That segregation has to be quite clear. And for cell force as such, I suppose any toxin which causes cardiac instability or cardiogenic shock, which is refractory to all therapy, ECMO becomes a treatment and standard of choice for that toxin. It could be cell force, it could be something else as well.
Okay. The last question to Dr. Raj, that what is the future of tele-ICU?
See, again, if we look at the country like India, where, see, I think more than 2 lakh, 3 lakh ICUs, and if you look at the qualified critical care specialists, is hardly 10,000, 15,000. So there is a huge scarcity. So if you, and the situation is becoming more promising after COVID, because in the COVID, the people have realized that you can treat the patient by means of telemedicine. Of course, all patients you can't treat. Some patients definitely require a thorough physical examination, but almost with a very good history, at least 60–70% patient you can treat. So physical consultation, this is not an alternative of physical consultation, but yes, there are so many good data globally that it reduced mortality, it reduced length of the stay, reduced the length of ventilator, and cost effective. We have a data of 1,700 patients in last 1 year, and there is significant reduction in mortality, because before that, there are no critical care specialists in the periphery. We have at the moment 10 centers, Disa, Visnagar, Surendranagar, Morbi, Dwarka, Veraval, Lunawada, Godra, Rajpipla and Vyara. So in these 10 patients, forget about the critical care specialists. Some few centers, they don't have physician also. So if you do even, they don't require a tertiary critical care. A basic critical care is also very, very helpful to save the life. So I think the technology, I look at that perspective, that the technology is helping to improvise your clinical care. That is most important. If you have data, and if you comprehend data and you find some good evidence, then that is beneficial for patient. So I think it has a good future. And country like India, where there is a huge scarcity of a qualified, trained critical care specialist or trained staff, I think it has a good future.
Yeah, it is evolving tele ICU concept, and I think because of time concern, we have to conclude here. Thank you very much. Thank you all panelists. Thank you.